All right. Thank you, Admiral Levine and Dr. Steinberg. Wonderful to hear those comments. And building on the theme of payment, our next topic is really going to focus on that. You may have noticed that a significant part and significant focus of PCC's efforts is really focused on how we pay for primary care and how much we pay for primary care. So to address that and dig a little bit deeper, we're going to invite Mark Del Monte and Dr. Paul Grundy to the stage to do just that. Please welcome them.
Thanks much. Hi, Paul.
Good to see you, Mark.
Good to see you, too.
This was real exciting, right?
Yeah.
I mean, we've been working on this for years together, and to hear HHS really take a focal point in trying to drive comprehensive primary care is just phenomenal. When we first started preaching about this, it was deer in the headlights, so it's pretty exciting.
That's true. If we go back there to the origin story, I think you're right. To think about coming back, as we sit here today, off of a NASM report and an anticipated work plan from HHS, it's been an incredible journey since 2005 and when it all got started. And I wonder if you could begin there. You were in corporate America, working at IBM, big employer, and started to get very focused on primary care. And can you talk about why the origin story of that energy?
Like much in life, a lot of it's fortuitous and what happened to timing and action. But, you know, I guess the foundation of it for me was I happened to be lucky enough to have Barbara Starfield as one of my professors when I trained at Hopkins in preventive medicine. We did a jam when I first became involved in providing care for our employees. We had about 1 million lives at the time, families and employees and retirees. And it was really frustrating in terms of what we bought. We did a jam, we did a 3-day jam where we asked our employees what they wanted out of the care that we helped buy for them. They wanted access, they wanted convenience, and they wanted a healing relationship of trust with the healer. And when we asked them who they trusted most in their life besides their family, it was their physician, right? It was their primary care physician. And when we looked at the data, less than half of our employees had one. But those who did have one cost us 1/3 less. If that was their normal regular source of care, and their mortality in a 20-year window from 45 to 65 was 19% lower. And as we were looking at this, my immediate big boss had kidney cancer, and I ended up providing care for him and holding his hand going through that treatment. So it developed a relationship, and he could see the results of what I would define as milking machine medicine, right? And so I used to go out and preach about we buy garbage in my slides, and Alan can probably recall some of those early talks. But just then, my big boss, the CEO, almost died of a drug-drug interaction. He had 5 specialists. What self-respecting CEO wouldn't have a specialist for every organ system without any adult supervision, right? Hence, he almost died of a drug-drug interaction. So we had a conversation around the boardroom there with head of HR. And so with that, we reached out to organize primary care. In fact, my first call was to Doug Henley, the head of AAFP, and I sat down across the table from him and said, we want to change how we buy. We want to buy comprehensive integrated care. And Doug said, bless your heart, he said. I now know it means 2 things. And, you know, we think what you pay for is pretty silly. We should be paying for anyway. So I did a call with Cal Shia, who was the first person to ever articulate the concept of a medical home. And what I learned from that call was that the medical home was a home for the data. Mm-hmm. If you're going to have information about a patient and they have complicated needs, you know, in this particular case, children with special needs, they're going to have a psychiatrist, they're going to have a psychologist, they're going to have schools, they're going to have teachers, parents. They all better sing from the same sheet of music. They all better have the same data, and they don't.
That's right.
You know? And then from my experience at UCSF with kidney transplant, you know, they kind of had to have a medical home then, right? Because their patients died if they didn't all coordinate. But they needed a multi-team approach to care because they were complex and integrated. So we reached out to organized primary care, and we asked them to get us a set of principles around a concept of care. The pediatricians called it medical home, family medicine called it the future of family medicine, internal medicine called it advanced medical home. And so they all gave us a set of principles that we could organize around. We then pulled together 47 of the largest employers in the country. And we pulled all of the healthcare companies that delivered plans for us, all the provider, all the plans, into a room and asked them, you know, to deliver this care, to do some pilots around this care. And they all agreed to do that. And when one of them backed out 6 months later, I took him to the New York Times woodshed. And as we agreed in the agreement we had with them and with the press release we did the next day, if you don't stick with this, we'll stop providing care for you. We'll stop buying your care. So 11 of us, or 14 of us, by 11 o'clock the next day, notified them that we weren't going to buy care from them anymore, right? So we had enough punch in the market. So John Englehart wrote an editorial at about that time. He was the editor of the New England Journal, I think, at the time. And Dr. Grundy is not the father of this idea. It really comes from pediatrics, right? It comes from the concept way back in the 60s of Calvin C. But surely he is the godfather because we had enough clout. We then tried to take this concept and sit down with government. So this is so cool to hear this conversation because they're the big gorilla in the room, right? 53% of all care comes from the federal government. And they paid fee for service. And we knew we had to change it. In fact, 3 things really have to change. You know, the cultural shift away from an episode of care to managing a population, that's the training, that's the education, that's the cultural awareness of your patients, of your providers. The second is payment change. I mean, there's only one way to hurt a cat, and that's to move the food. If you put the food in the wrong place, you're going to get the wrong set of services, right? And we were getting the wrong set of services. I mean, we had to move away from a button to bed as a profit to a button to bed as a cost to you, right? You want to keep them out of the bed. And the third, I think, and part of the reason why I was really excited about being part of IBM was the technology that allowed you to have information about those patients in front of you and those patients not in front of you, even more important, to do population health management. And, you know, when I was sitting in that room the next 2 or 3 days later around the table with my senior leadership, because this particular healthcare plan canceled their business with us. I was sitting there with the lady who became our CEO eventually, and she said, Dr. Grundy, I know you're known as the godfather of this idea, but we'd like to see a hell of a less horse heads in our business. And Randy McDonald, who I had been caring for, right, and who could see what needed to be done, said, oh no, he said, you know, please don't stop Dr. Grundy from doing this because we've got to do this. And besides that, the healthcare plans love it when we talk dirty to them.
Nice. So I think that's an interesting pivot point from the Godfather metaphor to a different one, because I think that enters the conversation that was sort of happening in those mid 2000s, where it was really the origin story of the patient-centered primary care collaborative, which is now the PCC. That table that got set at that time, that sort of multi-stakeholder table, where you were sitting around with big buyers and big payers and medicine and all the other stakeholders, including patient representation around that table, and having a conversation that could not be replicated in individual conversations without all of those people around the table was really an unbelievably new phenomenon. Because what I think, as you said, what had been going on previously was continuous articulations of the model of a delivery system that would work for families, right? So in the pediatrics example, it was the frustration of families in dealing with fragmented care systems. They had one conversation at school, one conversation at the hospital, a different conversation in their primary care setting. And so the kind of secret sauce of the PCC was this sort of multi-stakeholder approach in which there was a dialogue that was happening. And there was, I think, really impressive power in it. But at that point, would you say that what we're still talking about is the delivery system? What is primary care trying to transform medical home? What it was that payers were trying to buy or not buy, what purchasers were looking for their employees. And we hadn't really gotten to the core of it, which is the overall level of investment. But those early days of conversations were really focused on delivery system, I think, mostly.
Yeah, I mean, there's so much to that. I mean, I sort of look at change. I mean, I was brought over to help with the UK run some of their early pilots around what they call primary care medical homes. And Jeremy Hunt, the Secretary of State for Health, said, "How do I change healthcare in England?" And I said, "You're asking the wrong question. The right question is, how do I identify the early adapters and support them to change, and then find the early followers and begin?" And I think we're making progress towards that, right? But it's a long journey. I mean, it took us 50 years to implement Flexner when the report had been written in 1911. So I think, you know, one of the important things that you have to have, the sort of eight principles of social change, is that what you started may not happen in your lifetime. That takes some patience, right? I think what we started is really important. And when you look at like the VA and their delivery transformation, and you look at Indian Health Service, and you look at many other examples, I mean, just tremendous ability. That begins to drive that first and most difficult of the concepts, the cultural shift. The payment change, we made a little progress, I think. We've got, you know, language in CMI. We've got these folks at HHS talking about it. We have the National Academy of Medicine working on it. I mean, so you know, there's some big players in there driving that. But boy, we've got a long ways to go. I mean, fundamentally, if you look at delivery systems that work well, I mean, I happen to be very, very involved in Denmark. 21% of their spend is in primary care. 21%. Ours is 5%, right? I mean, you know, that just isn't enough to really drive that. So we've got, all of us out there, we've really got our work cut out for us. And probably payment change is one of the most important aspects of that. You know, in the Danish system, the primary care provider is the best paid specialist, and should be. Right?
Yes, agreed.
If you want to be a neurosurgeon, it's because you want to be a neurosurgeon, not because you're going to make a lot of money, right? And you know, so you probably get better neurosurgeons as well. But you know, that is the key. We're now at 93.7% of all care delivered at the primary care level in the Danish system, and we're shooting for 95. You know, but the Veterans Administration have learned from that experience. They also agree with the Danes, and the last place you want to put a frail elderly person is in a hospital. You want to care for them at home, you want to care for them at primary care, you want to do everything you can to keep them out of the hospital, right? Because that's a dangerous place.
Sure. And I think that's a perfect segue into where Better Health Now is landing at this point. You know, that we want to invest in what we want. That's primary care. We want to pay for better health as opposed to sick care. We want to overcome social and economic barriers to care through the primary care system. And so the central tenets of the campaign now are about sort of investments in primary care. And I think we were headed down this road inexorably over the last 15 years of the discussion around the PCC table. But from my perspective, I'm curious about your thoughts. It seems that COVID has now been the crucible for this. If there's anybody who had any doubts that the current payment system didn't work, We now know this to be a certainty. The payment system collapsed in the context of a pandemic. It didn't work for access for families. It didn't work for access to the primary care. It didn't work for access to the hospital or anywhere else. It created barriers to accessing even mental health services. And so I think that the current moment that we're in is just the right moment to talk about rebuilding the system on a primary care.
And where it was really, really broken was in the fee-for-service world, right? I mean, those places that were at risk did quite a bit better than those who were stuck with fee-for-service. And so I think that was a real learning experience for many of the folks out there who thought, well, maybe we should at least have some of our care, not in milking machine medicine, right?
Sure. Exactly. So what would be your prognostication then? As you've watched this from your post at IBM and then working over the last 15 years or more to sort of get us to this place, now that we're trying to accelerate payment reform and thinking about investments overall in primary care as a society, where would you advise us to head? What buttons should we push and what levers should we push?
I mean, I think we have some great examples now of where they have invested in primary care and seen better results. I mean, the person who heads the Milbank Foundation was the commissioner of insurance in Rhode Island and did a really great experiment there where they began paying primary care 1% more a year, seeing a huge savings overall in total cost, right? I mean, and that's been replicated in Oregon and other places across the country. I mean, I think we just really need to keep at it. I mean, we have some allies now, HHS. We have a lot with Liz in heading up CMMI. Yeah, I mean, I think the work of the PCC and you guys sitting in this room to complement what these guys are doing, the work of the VA, I mean, that's been phenomenal. I've got to digress 1 second and tell a story about that. So Kevin Grembach and myself and a bunch of folks were sitting around the room. I think it was the second or third week of the Obama administration, and Nancy Ann DePaul was driving healthcare reform then. And so we had this conversation about primary care. And Nancy Ann said, we don't like the term medical home. It works well in pediatrics, but not in geriatrics. And we want to call it high-touch primary care. And I said, high touch, high touch. By the way, this was on C-SPAN. It's probably still out there. That was the escort agency our governor got caught using. And by the way, that's true. And the person who was driving the medical home transformation at the VA decided to call it patient-aligned care teams, which is probably a better name. But
that's great.
I mean, I think I'm optimistic, but I'm patient.
One final thought as we wrap this journey here. I think there has been an underemphasis on primary care as a source of overcoming health disparities. And I think that we have been cataloging health disparities for decades, particularly racial and ethnic disparities, but across many domains. And I think one of the sort of important focus that the PCC is bringing to this work now in the thinking about primary care investments is making sure that we think about that with an equity lens from the very beginning. That if you're going to improve primary care, you have to improve health outcomes for everyone, and not just people who have the best access to the best healthcare services or the best health coverage. And so, how do we make sure that we're lifting all boats as the tide raises? I
mean, I think this is a really important point. And if you look at other countries where they invest in equity, where they have social services better than ours, they do a much better job. But when you change payment, and all of a sudden a button to bed is going to be a cost to a system and not a profit to a system, they're going to look at things like, my type 2 diabetics are all going to be hospitalized for hypoglycemia at the end of the pay period if they don't have food to eat, right? So I better look at that. I better address that. And I've seen that happen. I mean, I saw that in Iowa where a hospital at risk, began to address that issue with data, looking at the data, what was happening with their population. And they nipped it in the bud, right? A paper was written about that in the Sacramento Valley, just as an example. But I think if you begin to align some of these things, the cultural shift, the payment change, and the technology to allow for that understanding, boy, but the data's out there. I mean, we know, there's 86 public parameters about disparity in any community. There's social services available out there. If you take that and you integrate that into your care system, boy, you can begin to nip that in the bud. But the core of all of that, the underpinning of all of that, is a healing relationship of trust with a primary care provider, right? And that's the fundamental foundation you can build this on. I mean, there's no other thing you can build it on in the world. And the reason for that is that, when we do a functional MRI, we look at the part of the brain that deals with who your healer is. I grew up in Africa with traditional medicine. I mean, that need to have somebody in your life when the chips are down is an immense and important part. If you activate that, if you build your system of care on that, and then fund that, you're going to change how care is delivered, just unimaginably.
Well, Paul, as we wrap up, I heard some news this week that you might be retiring. And so I think I will take this opportunity, this public opportunity, on behalf of this whole community to thank you for being the godfather of this movement and to appreciate you for all that work that you have done. Thank you very much.